Hello, my name is Dr. Roger Blumenthal, and I'm editor-in-chief of the new dyslipidemia clinical community, which is now available on CardioSource. It gives me great pleasure to be talking with Dr. Erin Michos, a longtime collaborator who's an assistant professor of medicine at Johns Hopkins, member of the Johns Hopkins Ciccarone Center. And we're going to discuss a little bit about the treatment of dyslipidemia and risk assessment in women. Erin's published a lot on this topic, so Erin, welcome.
Thank you.
Well,
Roger and I, we've published a lot about risk assessment in women and some of our concerns with the previous Framingham risk score for hard coronary events, the ATP3 NCEP version, may really sort of underestimate risk in women. And this was highlighted by a series of studies, including one by Dr. Akosa and Jack in 2005 that showed women under the age of 65 who presented with their first myocardial infarction. If you were to calculate their Framingham risk score before their event, none of the women would have had a high risk score greater than 20%, and only 5% of women would have even been intermediate risk. And 95% of these women who presented with their first heart attack would have been low risk. And and clearly they were at increased risk because they presented with a myocardial infarction. And the concern is that, using the traditional Framingham risk score, that most women, even up to age 70, would be considered low risk, considered less than 10% per those guidelines, 10-year risk of hard coronary events. And if you looked at the NCEP ATP3 lipid guidelines, most of them wouldn't qualify for statin therapy unless their LDL was greater than 160 or 190, depending on if they had one or more risk factors. So, we were concerned that a lot of women, especially women who have substantial subclinical atherosclerosis, in some of the studies we published, would have been sort of underestimated their risk using the traditional Framingham risk score. And there has been some other risk scores, including the Reynolds risk score, which seem to discriminate a little better in women. And now with these new prevention guidelines, now there's a new pooled cohort risk score, which focuses on total hard atherosclerotic cardiovascular disease, which I think is really important because stroke events are actually more common than coronary events in younger women. And this emphasizes the sort of the global burden of morbidity and mortality of total cardiovascular disease. And so I think that's important now that stroke is being considered in the equation. But there is still some concerns I have about this new risk score. One of the concerns is that, it turns out again that the same traditional risk factors that we see in Framingham make it into this pool analysis. And, there's certain, notable absences of things that we know predict risk. For example, family history of premature coronary disease, which you and I had showed was an important marker of women who had a higher burden of subclinical atherosclerosis. And data suggests that individuals who have a strong family history of premature coronary disease of a first-degree relative less than 55, male relative, or less than 65 in a female relative, have a twofold increased risk of a cardiovascular event. And other guidelines, most notably the Canadian guidelines, have suggested that if you have a family history of a premature coronary disease in a relative, first-degree relative, that you could double your Framingham risk score. But I was concerned that this new pooled cohort score does not include family history. It wasn't clear that they had a premature history in all of the different cohorts where they analyzed. So I think that's a one place where they may be underestimated. They did say that if you do have a family history, that could be something that can be considered to move you up one risk category. The other notable thing that I think maybe this new risk score assessment falls short is in not taking into account subclinical atherosclerosis, notably coronary calcium in their model. So when they did this pooled score, they used cohorts, NHLBI-funded cohorts that had 10-year follow-up data like ERIC and Cardia and the cardiovascular health study, but notable absence, the multi-ethnic study of atherosclerosis, because they hadn't quite reached 10 years of events. And of course, MESA, is one of the most compelling cohorts that have shown the importance of coronary artery calcium. And I think if they had considered that in their risk model, it would have just maybe discriminated better than this pooled risk cohort. You mentioned earlier about C statistics, and I think this new risk score maybe has a C statistic, an area under the curve for predicting cardiovascular events about 0.7. I will point out that in MESA, when they looked at the traditional Framingham risk score variables in predicting risk of coronary events, the traditional model only had a area under the curve of 0.7, but when you added coronary artery calcium to that, the risk prediction, the area under the curve, moved to 0.8, and maybe even coronary calcium would do even better on its own. So it clearly it's been shown to add to the risk prediction model. In these new guidelines, they do say that in individuals where the decision to treat is uncertain, presumably this would be people who have a pooled risk score less than 7.5%, may be considered for alternate testing. And then they give kind of a list of alternate testing, such as having a C-reactive protein greater than 2, or a coronary calcium score greater than 300, or being above the 75th percentile, or having an ABI less than 0.9. But I feel sort of things are not all equal. That I think that coronary artery calcium is clearly superior to these, as we've seen in the MESA study. Some nice work by Dr. Blaha, one of our colleagues, had shown that in individuals who met the age and lipid criteria for the Jupiter clinical study, that C-reactive protein did not predict either coronary events or total cardiovascular events, where having a coronary artery calcium score, greater than 100, was a strong predictor of events, and would help discriminate those who might either benefit from statin therapy or who would least benefit from statin therapy. Individuals with coronary artery calcium scores of 0 have very low 5-year event rates and would have a very high number needed to treat if you were to give them statin therapy. So I am still concerned, that this continual focus on these risk scores that really focus on chronological age, and a man and a woman is only as old as their arteries. And I think, really the data seems to be moving towards a focus on, personalization and focusing on more biological arterial age. And I think it's a little bit remiss that they didn't give a more compelling push to consider subclinical atherosclerosis testing. I think that we may still end up with a lot of undertreatment and overtreatment of individuals by really focusing so much on chronological age.
Erin, those are great points. And in the last minute or two, I just wanted to get your thoughts on one other item. And the guidelines say that if you're above that 7.5% risk threshold, that even if your LDL is in that 70 to 100 range, that you should be treated. And listening to you, I think you make a very compelling argument that this risk score is dominated by chronologic age, that someone could have completely normal lipids, have a very low event rate over the next 10 years without any subclinical calcification, but yet it seems that the guidelines are recommending treatment even in these people with optimal lipid values. Is that your understanding too?
That's my understanding of the guidelines, and I'm a little concerned about that. 7.5% is still pretty low. I think in the guidelines they give the example of a man who has a 55-year-old man with a total cholesterol around 213, an HDL of 50, and a systolic blood pressure of 120 would only have about a 5% or so total hard cardiovascular event rate. But in that person, I would still feel a little cautious about giving a statin, particularly if we're on the fence. I would consider getting a coronary artery calcium score. If he had a score of 0, he would be, predicted to have a very low event rate over the next 5 years, and was not anticipated to really benefit from that statin therapy just because the absolute event rate is so low.
Erin, those are all great points, and just because of time, I think what we'll do is we may stop here. I wanted to thank you so much for your great insights. We're going to welcome you back to this clinical community very frequently during the coming year. I hope the audience will visit the community frequently for ongoing information about dyslipidemia. Again, it was a great pleasure to interview my longtime colleague, Dr. Erin Michos, and this is Dr. Roger Blumenthal for the CardioSource Clinical Community on Dyslipidemia. Thanks again, Erin.
Thank you.